Infections of the reproductive tract can occur throughout a woman's lifespan and are often the cause of significant reproductive morbidity. The direct economic costs of these infections can be substantial, and the indirect costs equally overwhelming. The emotional costs may include damaged relationships and lowered self-esteem. One of the more important and also more difficult things you may be expected to do is to take a sexual history on your patient. I cannot stress enough how critical it is that you approach this task with your best empathetic, non-judgmental demeanor. You have to use excellent communication skills. You should use language that the patient can understand and explain any technical terms. It is important to use open-ended questions, such as, what, if anything, would you change about your sex life, in order to obtain important sexual history. Also, you should look for teachable moments. You may be the first person to explore this area with them, and you may be in the position to provide valuable information about their bodies. Don't concentrate on writing everything down as they are speaking. Allow it to be a conversation, and leave the charting for after the patient has gone. Recognize you can help with what you can't, and be prepared to make referrals as needed. Many times, the only time we have the opportunity in the community to address a woman's health is if they come to us for birth control, pregnancy, or an STI. In this lecture, we will discuss some of the most common STIs and how they can be diagnosed, treated, and prevented. STIs are a significant health challenge globally, which pose a serious threat not only to women's sexual health, but also to the general health and well-being of millions of people worldwide. It constitutes an epidemic of tremendous magnitude. An estimated 65 million people live with an incurable STI. 18,000 die from acquired immune deficiency syndrome, or AIDS, annually, and another 20 million are newly infected each year. STIs are biologically sexist, presenting greater risk and causing more complications among women than among men. Women are diagnosed with 2/3 of the estimated 20 million new cases of STIs annually in the United States. STIs may contribute to cervical cancer, infertility, ectopic pregnancy, chronic pelvic pain, and death. Certain infections can be transmitted in utero to the fetus or during childbirth to the newborn. Nurses should always address a woman's psychosocial well-being whenever a diagnosis of any STI is given. Women may be afraid or embarrassed to tell her partner and ask him or her to seek treatment. Some cultures place very high values on virginity and fidelity. A diagnosis of an STI can be devastating to the woman and her family. Nurses implementing STI prevention strategies must also acknowledge the possible role of violence in increasing women's risks as a barrier to practicing safer sex. Research suggests a strong association between intimate partner violence and STIs. STIs know no gender, class, racial, ethnic, or social barriers. All individuals are vulnerable if exposed to the infectious organism. Nurses working with women from diverse cultures need to be cognizant of effective methods of STI prevention. By adopting a multicultural approach to the control of STIs, nurses can address specific cultural and religious attitudes and behaviors that influence exposure to STIs. 2/3 of all STIs occur among persons under the age of 25. 47% of high school students report having been sexually active. Recommendations for sexual health education and STI prevention targeting adolescents before the start of intercourse is recommended. Because of biologic and behavioral factors, adolescents are at particularly high risk of acquiring STIs and for the serious, long-term, potentially life-altering sequela that can develop from undiagnosed, untreated infections. Sexually transmitted infections are primarily transmitted by sexual contact. It includes more than 25 infectious organisms that are transmitted through sexual activity and the dozens of clinical syndromes that they can cause. STIs are among the most common health problems in the U.S. today, with an estimated 15 million people in the U.S. being infected with STIs each year. STIs can be spread by any kind of sex, vaginal, anal, or oral. They can even be spread via inanimate objects such as sexual toys. STIs are caused by one of three types of organisms. It's really four. And we'll talk about each of the main ones. But on this slide, we do have five because we're including funguses. Parasites, being your first one that we will cover, are small animals that get nourishment from the person they infect or the host. Crabs, pubic lice, would be a common STI from this class. Parasitic infections can be treated with either prescription medication or over-the-counter drugs. Another classification is bacteria, which are one-cell organisms that cling together to feed from the body of their host. Gonorrhea, syphilis, and chlamydia are all examples of this class. Bacterial infections can be treated with antibiotics. Viruses are another category. These are complex molecules that can multiply when they invade the cells of their host. HIV and herpes are both examples of this type. Viruses are unique in that although they can be controlled, once contracted, they can never be cured. Protozoa, another category, usually are one-cell organisms with a flagella or a tail. And then we have funguses, which are usually just Candida, and Candida albicans is your most common. It is important to realize that a person can and most likely has more than one STI at a time. So it is vital that you, while investigating symptoms, you do test for more than one STI. We're going to separate the sexually transmitted infections that we're going to cover by their characteristics of symptoms. So the first ones are infections that are characterized by vaginal discharge. And these will include genital and vulvar-vaginal candidiasis, trichomonas, and bacterial vaginosis. Your other category is going to be infections that are characterized by cervicitis or an inflammation of the cervix, and these will include chlamydia and gonorrhea. Infections that are characterized by genital ulcers are going to include genital herpes simplex, syphilis, and pelvic inflammatory disease. And then we have those infections that are vaccine preventable infections. And these will include the human papillomavirus, hepatitis A and B, and hepatitis C. We also have a little bit of information regarding your Zika virus disease and your human immunodeficiency virus, which is also falls in kind of its own category. So we start with infections that are characterized by vaginal discharge. Vulvovaginal candidiasis, or a yeast infection, is the second most common type of vaginal infection in the U.S. The most common organism is Candida albicans, and it is estimated that 80 to 95% of the yeast infections in women are caused by this specific organism. Numerous factors have been identified as predisposing a woman to yeast infections, including antibiotic therapy, uncontrolled diabetes, immunosuppressive states, and pregnancy. As all women are well aware of, the most common symptoms of yeast infections are itching, burning, and vaginal irritation. These symptoms can be mild or intense and may interfere with rest and activities. When discharge is present, it is most often thick, white, lumpy, and cottage cheese-like. Male partners of infected women usually don't have any symptoms, but occasionally a man will experience a rash and a burning sensation that is very temporary and goes away without treatment. Diagnosis always starts with a careful history of a woman's symptoms and any predisposing risk factors. A physical examination should always include a thorough inspection of the vulva and the vagina. Wet smears and vaginal pH are usually obtained in order to aid in diagnosis. There are a number of antifungal preparations available both by prescription and over the counter. The first time a woman suspects that she may have a yeast infection, she should seek a healthcare provider for a confirmation of the diagnosis and treatment recommendations. Any subsequent infections may be self-treated. However, women should be counseled regarding seeking care for numerous recurrent or chronic infections, as this can be a precursor to early signs of diabetes or HIV infection. If a pregnant woman has an active yeast infection during labor and delivery of her newborn, the infant can get a candida infection of the eyes or the mouth. Our next one that falls in this same category is trichomonas. And trichomonas is another common vaginal infection that causes a discharge, but it is not always sexually transmitted. The organism can live on damp, wet surfaces and poorly cleaned, maintained hot tubs and drains. Trichomonias is caused by the Trichomonas vaginalis protozoa, which is an anaerobic, one-celled protozoan with characteristic flagella. It lives in the urethra of men and most often in the vagina of women. It is usually sexually transmitted, but can be contracted by shared bathroom facilities or wet towels or swimsuits. Although trichomonias is often asymptomatic, women who do experience or present with symptoms will experience a characteristically yellowish to greenish, frothy, mucopurulent, copious, malodorous discharge. Inflammation of the vulva, vagina, or both may be present, and the woman may complain of irritation and pruritus. Symptoms appear within 4 to 20 days of exposure, and men partners almost never have any symptoms. Diagnosis always involves, like all other STIs, a careful sexual history and a history of the current symptoms. A wet smear with normal saline will reveal that typical one-celled flagellate trichomonads. The recommended treatment, as per the CDC, is metronidazole 2 grams orally in a single dose. It is preferred to treat both partners because men can transmit the disease even though they are asymptomatic. It is important to stress that both partners are treated to avoid recurrence of infection. Alcohol should also be avoided while taking flagyl because it can result in severe nausea and vomiting. Untreated trichomonas increases the risk of HIV infection. Pregnant women with trichomonas are at increased risk for preterm labor and delivery and low birth weight infants. Another bacterial infection that is characterized by vaginal discharge is bacterial vaginosis. Bacterial vaginosis, or Gardnerella, is the most common type of vaginitis today. It is a syndrome in which normal H2O2 producing lactobacilli are replaced with high concentrations of anaerobic bacteria. Most women with BV complain of a characteristic fishy odor. It is even more pronounced after intercourse. However, 50% of women who have BV will not report any symptoms at all. When symptoms are present, the discharge is usually profuse, thin, and white or gray or milky in appearance. There may also be some irritation or pruritus. It is diagnosed by examining vaginal fluid under a microscope. The healthcare provider makes the diagnosis based on a lack of lactobacilli. The odor, which is referred to as a positive whiff test, and the presence of clue cells, which are cells from the vaginal lining that are coated with BV organisms. Our whiff test is a test that providers use in order to be able to diagnose BV. And it is when they take a sample of the vaginal discharge, dip it into a small amount of KOH, which is potassium hydroxide, and when they take a whiff, they have the positive odor of the fishy odor. Nursing management or treatment is indicated with oral metronidazole or flagyl, and that is the most effective treatment option. And the male partners are also generally not treated. BV is associated with preterm labor and delivery, so pregnant women also should also be screened and treated for this as well. As a nursing consideration, patients should be informed that, again, when oral metronidazole is taken, The woman should not drink alcoholic beverages because she will experience the severe side effects of abdominal distress, nausea, vomiting, and headaches. We will now talk about infections that are characterized by cervicitis. Chlamydia is a curable bacterial infection that can be transmitted by oral, vaginal, or anal sex with an infected partner. Chlamydial bacteria lives in vaginal and seminal fluid. It is the most common and fastest spreading STI among U.S. women. The Center for Disease Control estimates that there are more than 4 million people infected with chlamydia each year. Risk factors will include those young over 25, recent change in sexual partners or multiple sexual partners, poor socioeconomic conditions, exchange of sex for money, non-white race, single status, and lack of use of barrier contraception. It is often asymptomatic in both male and females. Although infection is usually asymptomatic, if it does present with symptoms, they will appear about 1 to 3 weeks after exposure. A patient may experience abnormal discharge that is mucoid or purulent. They may experience burning or pain with urination, dysuria, or lower abdominal pain. Men can have urethritis, and women will present with cervicitis. Mucopurulent vaginal discharge, urethritis, bartholinitis, endometritis, salpingitis, and dysfunctional uterine bleeding are all common symptoms that can occur with untreated chlamydia. It can be the cause of infertility and blindness in newborns. This is due mostly because chlamydia is known as the silent disease. Chlamydia is especially dangerous because it tends to be an ascending infection, meaning that it moves upward in the body if left untreated. It destroys the fallopian tubes and can cause pelvic inflammatory disease, which is a leading cause of infertility today. It also increases the risk of cervical cancer in women. In men, it can cause epididymitis. Diagnosis of chlamydia is by culture, which is expensive and labor intensive. The DNA probe, which is less expensive but less sensitive, is an enzyme immunoassay, which is also less expensive but much less sensitive, and nucleic acid amplification, which is expensive but has a sensitivity of about 90%. The DNA probe is the most common way of diagnosing chlamydia today. The CDC recommendations for treatment of chlamydial infections are doxycycline 100 milligrams orally twice a day for 7 days, or azithromycin 1 gram orally in a single dose. Because only 1 dose is needed, azithromycin is often prescribed for compliance purposes. A pregnant woman is treated with erythromycin or amoxicillin. Because chlamydia is asymptomatic, patients should be cautioned to take all medications prescribed for their entire duration. A test of cure is usually done within 4 to 6 weeks after treatment to assure the absence of infection. Patients should also be tested for gonorrhea and it is often a very common co-infection. I usually like to call them BFFs. Most often, patients are treated for both STIs since it is so very common that the patient is infected with both. So, its BFF, gonorrhea, is caused by the aerobic gram-negative bacteria, Neisseria gonorrhoeae. It is almost exclusively transmitted by the contact of sexual activity. Principally, the communication is genital to genital. However, it is also spread by oral to genital and anal to genital contact. It can also be transmitted to the newborn in the form of ophthalmia neonatorum, during both by direct contact with gonococcal organisms in the cervix. Women are often asymptomatic, but when they do present with symptoms, they may have a greenish, yellowish, purulent endocervical discharge, or a chronic and acute severe pelvic or lower abdominal pain. They may also include bleeding with intercourse and irregular menstruation. Men usually have symptoms more often than women. They are also more dramatic. Men will present with a white, yellow, or greenish pus from their penis. Pain will drive them in for treatment. It is often much easier to diagnose in men than it is in women. With that said, however, gonococcal infection cannot be diagnosed reliably by just clinical signs and symptoms alone. Cultures are considered the gold standard for diagnosis of gonorrhea. Because STIs tend to coexist, patients suspected of having gonorrhea should have a chlamydial culture done as well. Remember, BFFs. Management. The CDC now recommends dual therapy, i.e., using 2 separate drugs, as the treatment for gonorrhea. Dual drug therapy is recommended to prevent drug resistance and is also effective against chlamydia. Ceftriaxone, which is Rocephin, 250 milligrams plus a single dose of azithromycin, 1 gram orally, or doxycycline, 100 milligrams orally twice a day for 7 days, is the recommended regimen. The CDC also suggests concomitant treatment for chlamydia because co-infection is so common. Because gonorrhea is a highly communicable disease, most treatment failures result from reinfection. During management, the nurse is responsible for educating the public about the increasing incidence of these infections. Information should include high-risk behaviors associated with these infections, signs and symptoms of the infection, and the treatment modalities that are available. Stress that both of these STIs can lead to infertility and long-term sequelae. Nurses must help to teach safer sex practices to their public in non-monogamous relationships. Now we talk about infections that are characterized by genital ulcers. Genital herpes simplex virus, or HSV, is now one of the most common STIs in the U.S., especially in women. HSV is a painful vesicular eruption of the skin and mucosa of the genitals caused by 2 different antigen subtypes, HSV1 and HSV2. Although HSV1 is more commonly associated with oral labial ulcers or fever blisters, and HSV2 with genital lesions, neither kind is exclusive to either location. It is estimated that at least 1 in every 5 people in the U.S. is infected with herpes. The infection rates are higher in women between the ages of 15 and 34. The initial herpetic infection usually has both systemic and local symptoms, and it lasts about 3 weeks. The first symptom after incubation are genital discomfort and neuralgic pain. Systemic symptoms can be fever, malaise, headache, and photophobias. The lesions progress from macules to papules, then vesicles, pustules, and ulcers that will crust and heal without any scarring. Ulcerative lesions last about 4 to 5 days before crusting over. With recurrent episodes, systemic symptoms are usually absent, although the characteristic prodromal genital tingling is common. They are usually unilateral, are less severe, and usually last 7 to 10 days without prolonged viral shedding. Diagnosis is confirmed with viral tissue cultures along with a history and physical. Genital herpes is a chronic and recurrent disease for which there is no known cure. Oral medication used for treating HSV include acyclovir, famciclovir, and valciclovir. Management is directed toward specific treatment during primary and recurrent infections and prevention. Patients should be helped to understand when viral shedding and therefore transmission to a partner is most likely to occur, and that they should refrain from sexual contact from the onset of prodromal symptoms until complete healing of the lesion. Stress, menstruation, trauma, febrile illnesses, chronic illnesses, and ultraviolet light have all been found to trigger recurrences of genital herpes. The emotional effect of contracting an incurable STI, such as herpes, is considerable. Feelings of helplessness, anger, denial, guilt, anxiety, shame, or inadequacy can occur. Herpes can affect a patient's sexuality, sexual practices, and their current and future relationships. They need the opportunity to discuss their feelings and help in learning to live with the disease. Living with genital herpes can be difficult due to the erratic, recurrent nature of the infection, the location of the lesions, the unknown causes of the recurrences, and the lack of a cure. In pregnancy, HSV can cause systemic infection in the newborn. The infants can develop serious problems that may affect the brain, skin, or eyes. Therefore, for those women with active lesions at the time of labor, a C-section is the gold standard for delivery options. Along with the increase in the incidence of genital herpes, has been an increase in neonatal HSV infections as well, which are associated with a high incidence of mortality and morbidity. The risk of neonatal infection with a primary maternal outbreak is between 30 to 50%. It is less than 1% with recurrent maternal infections. Most women with a history of HSV are now being treated with valacyclovir starting at 36 weeks gestation until after delivery as a preventative measure against asymptomatic shedding. Another infection characterized by genital ulcers is syphilis. Syphilis is caused by Treponema pallidum, a motile spirochete. Its transmission is thought to be by entry in the subcutaneous tissue through microscopic abrasions that can occur during intercourse. It can also be transmitted through kissing, biting, or oral genital sex. Transplacental transmission can occur at any time after the 10th week of pregnancy, and the degree of risk is related to the quantity of spirochetes in the maternal bloodstream. Syphilis has been on the decline for years, but for the first time in 2001, the number of cases actually rose. Rates are continually higher in the southern states according to the CDC in 2003. But its incidence is on the rise in certain populations. Those in populations of gay men, bisexual men, men having sex with men, and women of color living in the South. Syphilis is a complex disease that can lead to serious systemic disease and even death if left untreated. The infection manifests itself in distinct stages with different symptoms and clinical manifestations in each stage. It increases the risk of acquiring HIV by 3 to 5 times. If left untreated, could lead to infections such as hepatitis, stroke, nervous system damage, and ultimately death. Primary syphilis is characterized by a primary lesion, which is the canker, that appears 5 to 90 days after infection. This lesion often begins as a painless papule on the site of inoculation and then erodes to form a non-tender, shallow, indurated, clean ulcer several millimeters to centimeters in size. It will eventually go away within 10 days to as long as 3 months, but usually within 4 weeks. Secondary syphilis occurs 6 weeks to 6 months after the appearance of the canker. It is characterized by a widespread symmetric macular-papular rash on the palms and soles and generalized swollen lymph glands. The patient may also experience fever, headache, and malaise. Condyloma lata, which are wart-like infectious lesions, may develop on the vulvar, perineum, and anus. It is important to know that the bacteria are present in the sore, so any contact can spread the infection. These two phases above are highly contagious. If left untreated at this point, the patient will enter a latent phase that is asymptomatic for most individuals. The patient now is not contagious in the latent phase, and a lot of people who enter the phase will not have any more signs or symptoms of the disease. Unfortunately, about 1/3 of individuals who have not been treated up to this point will develop tertiary syphilis. Neurologic and cardiovascular, musculoskeletal, or multi-organ system complications can develop in this phase. This phase can last for decades and can result in mental illness and death. The oral manifestations are the gumma. The gumma appears as a firm nodular mass that ulcerates and that may, when located in the palate, ultimately perforate it. The diagnosis is dependent on microscopic examination of primary and secondary lesions and on serology testing during the latency phase of the infection. Any testing for antibodies may not be reactive in the presence of active infection because it takes time for the body to develop antibodies. There are two types of serologic tests used: your non-treponemimal and treponemimal types of tests. Your non-treponemimal test, like your VDRL or the RPR, are used as screening tests. False positives are not unusual. Treponemial tests, like the fluorescent treponemal antibody absorbed FTA-ABS, and the microagglutination assay for antibody to T. pallidum, are much more accurate and are usually used to confirm results. Seroconversion usually takes place 6 to 8 weeks after exposure, so testing should be repeated in 1 to 2 months when a suspicious general lesion is found. Penicillin is the preferred medication for treating patients with all stages of syphilis. The recommended dose is penicillin G benzathine 2.4 million units IM in 1 dose. Syphilis easily passes through the placenta, and 40 to 70% of infected women will give birth to a baby with syphilis. The newborn lesions are highly infectious, and all healthcare providers must use universal precautions when caring for these infants. Pelvic inflammatory disease is an infectious process that most commonly involves the uterine fallopian tubes, uterus endometritis, or the uterus itself, and more rarely their ovaries and peritoneal surfaces. Most common causative agents was thought to be gonorrhea. However, chlamydia is now estimated to cause half of all the cases of PID. PID results from ascending spread of microorganisms from the vagina and endocervix to the upper genital tract. Risk factors for acquiring PID are those associated with the risk of contracting an STI, including young age, nulliparity, multiple partners, high rates of new partners, and a history of STIs and PID. Women who use IUDs may be at increased risk for PID up to 3 weeks after insertion. Women who have PID are at increased risk for ectopic pregnancy, infertility, or chronic pelvic pain. Symptoms vary depending on whether the infection is acute, subacute, or chronic. Pain is common to all types. Pain may be dull, cramping, and intermittent, or severe, persistent, and incapacitating. Women also report one or more of the following: fever, chills, nausea and vomiting, increased vaginal discharge, symptoms of UTI, irregular bleeding, and abdominal pain. Screening and diagnosis may be difficult to diagnose because of the accompanying wide variety of symptoms. CDC recommends treatment for PID in all sexually active young women who have the following criteria: lower abdominal tenderness, bilateral adnexal tenderness, and cervical motion tenderness. Management. Most important intervention is prevention. Primary prevention includes education about preventing STIs. Secondary prevention includes preventing a lower genital tract infection from ascending to the upper genital tract, promoting self-protective behaviors, practicing risk reduction measures, and using barrier methods. Detecting asymptomatic gonorrhea and chlamydial infections through routine screening is a priority. Table 7.3 in your book covers the parenteral and oral treatment for PID. Health education is central to effective management of PID. Must explain to women the nature of their disease and encourage them to comply with all therapy and prevention recommendations. Now we reach the vaccine preventable STIs, and we will start with human papillomavirus. HPV, also known as genital warts, is the most common viral STI seen in ambulatory health care settings. An estimated 20 million Americans are infected with HPV, and about 6.2 million new infections occur every year. HPV has more than 30 different serotypes that can be sexually transmitted, 5 of which can cause genital wart formation, and 8 of which are currently thought to be precursors to cervical cancer. The risk factors will include multiple sex partners, age between 15 and 25, sex with a male who has had multiple sexual partners, and first intercourse at age 16 or younger. Lesions can show up anywhere in the genital area, most commonly on the vulva, vagina, anus, and cervix. They are small, soft, moist, papillary swellings that often appear in clusters that look like cauliflower. They are transmitted by skin-to-skin contact during intercourse. About 2/3 of those who have sex with an infected person will develop warts within 3 months after contact. Genital warts are often painless, but may also be very uncomfortable, particularly when they are very large. They can become inflamed and ulcerated. Untreated warts may resolve on their own in the younger patients as their immune system is strong enough to fight the HPV infection. Treatment focuses on prevention through HPV vaccine and education, and on treatment of visible lesions. The vaccine, also known as Gardasil, is given in 3 separate 0.5 ml doses in any individual from ages 9 to 26. The second dose is given 2 months after the first, and the third dose given 6 months after the initial dose. If treatment is needed, a topical application of trichloroacetic acid, 80 to 90%, or topical imiquimod 5% cream, or topical podophyllin 10% to 25% concentration. They can also be frozen off with cryosurgery or burned off with electrocautery or laser. The warts can be removed, but the virus always remains in the body. Women with HPV should have frequent pap smears to monitor for cervical changes. Genital warts can enlarge during pregnancy. They can interfere with the birth process by obstructing the vagina or making it less elastic. Patient counseling is essential. Women must understand the virus, how it is transmitted, that no immunity is received with infection, and that reinfection is likely with repeated contact. Torch infections is a group of infections caused by viruses and protozoa that cause fetal anomalies, miscarriage, and fetal death. Toxoplasmosis can be contracted by ingesting undercooked meat, so no raw or rare meats during pregnancy. This includes sushi. It can also be contracted from cats or the feces of cats, so no cleaning the litter box while pregnant, and she should wear gloves if she does any gardening, because it can also be in the soil. Other infections will include in this category hepatitis A and B are most likely. Hep A comes from fecal oral contamination, so most people contract it from contaminated food. It's highly contagious, self-limited disease that does not result in any other chronic infection. Hep B is transmitted in blood and body fluids, such as saliva, blood, semen, vaginal secretions, also through sexual contact with an infected partner, injection drug users, and through birth to from an infected mother. Risk factors will include multiple sex partners engaging in unprotected intercourse. Prevention of transmission of both A and B is pre-exposure immunization. Vaccines are available for both A and B. Everyone seeking treatment for an STI should be considered for a candidate or as a candidate for HPV vaccine or HAV vaccine. Hep A is usually self-limiting and does not result in any chronic infection. Hep B can cause serious, permanent liver damage. Treatment is usually just supportive. The Zika virus will also fall in this category, has been added to this group in September of 2016 as a newest member, transmitted primarily through the bite of an infected Aedes species mosquito during the daytime. Most common symptoms is fever, rash, headache, bone pains, joint tenderness, and conjunctivitis. Symptoms usually are mild, lasting several days to a week. Parvovirus and HIV are blood-borne and are also part of this group of other in this category of torch infections. The R represents for rubella. Rubella, due to vaccinations, this is not as likely as it once was, but we still see pregnant women who do not have immunity. CMV, cytomegalovirus, is spread like the common cold. Most people have had it already, so it is only dangerous if contracted for the first time during pregnancy. It is part of the herpes virus group. And then our last H stands for herpes simplex. And the risk to the baby from herpes is highest if the woman gets it for the first time during her pregnancy. Primary infection comes with systemic involvement. The virus spreads into the bloodstream and can cross the placenta. The women can be given Zovirax or acyclovir during pregnancy, which is an antiviral that is used to treat herpes. If the woman has visible lesions or symptoms of a genital herpes or hepatic lesion at the time of delivery, a cesarean section is usually recommended. Sexually transmitted infections with HIV, human immunodeficiency virus. We don't hear as much about HIV as we used to, and that's partly because of how good we have gotten at treating the disease. People are living for years now with HIV without getting AIDS. Despite the lack of media attention, HIV has not gone away. About 40,000 new HIV infections occur in the U.S. each year. An estimated 30% of these new infections occur in women. Transmission of HIV, which is a retrovirus, occurs primarily through exchange of body fluids, semen, blood, vaginal secretions, and breast milk. Infection undergoes 3 distinct phases: acute seroconversion, asymptomatic infection, and then progression to AIDS. Acute primary infection includes symptoms such as fever, pharyngitis, rash, and malaise. Seroconversion means that once HIV enters the body, seroconversion to HIV positivity usually occurs within 6 to 12 weeks. Although HIV seroconversion is usually asymptomatic, it usually is accompanied by an influenza-like response. Symptoms may include fever, headache, night sweats, malaise, generalized lymphadenopathy, nausea, diarrhea, weight loss, sore throat, and a rash. HIV infection is usually diagnosed by using HIV-1 and HIV-2 antibody tests. Diagnosis will occur by doing antibody testing. It is done first with a sensitive screening test such as the enzyme immunoassay. Reactive screening tests must be confirmed by an additional test, such as the Western blot or an immunofluorescence assay. HIV antibodies are detectable in at least 95% of patients within 3 months after an infection. Tests are designed to detect antigens, antibodies, or RNA. Enzyme-linked immunoabsorbent assay, if the ELSA is positive, a confirmation test like the Western blot test is then performed. HIV and pregnancy. The fetal and neonatal effects of acquiring HIV through perinatal transmission are devastating and eventually fatal. An infected mother can transmit HIV infection to her newborn before or during birth and through breastfeeding. Most cases, 90% of cases, occur late in pregnancy or during delivery. Pregnancy itself is not encouraged in the HIV positive woman. Preconception counseling is recommended because exposure to the virus has a significant impact on the pregnancy, neonatal feeding method, and neonatal health status. HIV positive women should be encouraged to seek prenatal care immediately if they suspect pregnancy to maximize the chances for positive outcomes. HIV screening in pregnancy is recommended for all women. However, it is strictly voluntary and must be done under informed consent. Approximately 230 to 370 infants born with AIDS are a result of transmission of the virus from mother to child during the perinatal period. Exposure to the fetus may occur through the maternal circulation, during labor and delivery, and or through breast milk. The frequency of perinatal transmission has been reported to vary from as low as 5 to 10% to as high as 50 to 60%. Treatment of HIV-infected women with the triple drug antiviral drug during pregnancy, cesarean birth, and a non-breastfeeding feeding method can reduce the risk of vertical transmission all the way down to 2%. HIV positive women are probably at risk for preterm labor and delivery, premature rupture of membranes, intrauterine growth restricted infants, perinatal mortality, and postpartum endometritis. IV antiretroviral medication is given to the HIV positive women while in labor. Every effort is made during the birthing process to decrease the neonate's exposure to infected maternal blood and secretions. Women who give birth by cesarean section with intact membranes and before labor starts can decrease their maternal infant transmission by 50% even if they have never been treated during their pregnancy. It is important for the mothers to understand that the infant may have a false positive HIV test for the first 15 months of life. This is due to passive antibody transfer from the mother. It cannot be determined if they actually have the disease or not in most cases until they are older than 15 months old. Treatment for these infants are similar to those for their mothers and continues until the infant is no longer HIV positive. Infected infants usually appear perfectly normal in the early months of life. In those cases where the disease progresses during the first year of life, the progression will be rapid and the child is unlikely to survive beyond the age of 4. This happens in about 20% of all infected children. In the other 80%, the progression of the disease is slower. Many HIV-infected children do not grow normally and are slow to reach developmental milestones. As with adults, they tend to get opportunistic infections that can be life-threatening. Early intervention as infants is the best protection. Current therapy to prevent the transmission of HIV to the newborn includes a 3-part regimen. The mother takes an oral antiretroviral agent at 14 to 34 weeks of gestation, and it is continued throughout the entire pregnancy. During labor, an antiretroviral agent is administered intravenously until delivery. An antiviral syrup is administered to the infant within 12 hours after birth. And of course, the mode of delivery is a cesarean section. Therapeutic management. The goals of therapeutic management are to decrease the HIV viral load below the level of detection, restore the body's ability to fight off pathogens, improve the client's quality of life, and to reduce HIV morbidity and mortality. Highly active antiretroviral therapy combines at least 3 antiviral drugs, as has dramatically improved the prognosis of HIV and AIDS. Risk factors and prevention. Risk factors for sexually transmitted infections and obtaining and doing a history to determine the risk factors is a crucial first step for the nurse to be able to include questions about a woman's sexual history, sexual risky behaviors, and drug-related risky behaviors as part of the assessment process. Both male and females have the same high risk factors for STIs. Behaviors such as multiple sex partners, unprotected intercourse, anal intercourse, partners' involvement with other partners, and young age of onset of sexual activity can all contribute to a high risk for STIs. Nurses have the responsibility to ensure that their patients have accurate, complete knowledge about transmission and symptoms of STIs and risky behaviors that place them at risk for contracting these infections. Reassuring the patient that treatment will be provided regardless of ability to pay, language spoken, or lifestyle. Although levels of awareness of STIs are generally high, widespread misconceptions or specific gaps in knowledge also do exist. Preventing infections is the most effective way of reducing the adverse consequences of STIs. Preventing the spread of STIs requires that women at risk for transmitting or acquiring infections change their behavior. Primary preventative measures are individual activities aimed at deterring infection. These include education and counseling, immunization for Hep B and HPV, education on the use of latex condoms, identifying infected individuals to diagnose and treat and include partners of the infected patient. When risky behaviors are identified, the nurse has an opportunity to provide risk reduction measures. These include counseling. We must include techniques that are effective, including open-ended questions, using understandable language. 2, it is no aspect of prevention is more important than knowing one's partner. And 3, condom use, physical barrier. Nurses can promote condom use as a prevention to STIs by initiating a discussion with them from the beginning. And 4 is behavior modification, making sure that the patient is aware that reducing her risks of STIs includes modifying her risk-taking behaviors. Thank you for listening to this lecture, and good luck on your exams.